And with me, I have Dr. Westin Childs, and we are going to be discussing unwanted weight gain in both hyperthyroidism and Hashimoto's. So let's go ahead. I'm going to give Dr. Childs' bio right here, and then we are going to dive into the content. So Dr. Westin Childs is a former osteopathic physician that focuses on helping people with thyroid problems, weight gain, and hormone imbalances. He takes a functional medicine approach to these systems and believes that everyone, regardless of their hormone status, can get back to feeling 100% using a combination of natural and medical therapies. So it's great to chat with you again, Dr. Childs.
It's good to be here, Dr. Osansky. Thanks for having me on again.
Yeah, we already have had you on my podcast and on YouTube, so it's great to talk with you again. And again, this time we're going to be talking about weight gain, problems losing weight. So I'm sure there's some people with hyperthyroidism maybe viewing this and thinking, "Hey, I'm losing weight," which is also common. When I dealt with hyperthyroidism, I lost 42 pounds. But there are some people with hyperthyroidism where it's the opposite problem. I just, and some people, when they become hyper, they're hoping to lose weight because most people with hyperthyroidism are women. Not that men don't want to lose weight, but either way, whether you're male or female, a lot of people want to lose weight when they realize they're hyperthyroid, and yet they're gaining weight, and they're like, "Hey, what's the deal with this?" I see that weight loss is a classic symptom. Of course, with Hashimoto's, it's common for people to gain weight. Either way, we know that weight gain is common with hypothyroidism, Hashimoto's, and in some people with hyperthyroidism. Why is that? What are some of the reasons why some people with hyperthyroidism gain weight and not lose weight?
Yeah, that's a great question. And I think in order to kind of talk about this, we have to get clarity on what we mean by hyperthyroidism and hypothyroidism. From our perspective, and I kind of want to talk about the way that I am seeing patients and kind of the way that was seeing patients, the way that you're kind of seeing patients. And I think it'll make a lot of sense as we kind of dive into this. But traditionally, we think about hyperthyroidism as having too much thyroid hormone, right? It's somebody who's producing too much thyroid hormone. That thyroid hormone is overstimulating their body in various ways. It's causing a rapid heart rate. It's causing their hair follicles and cycles to rapidly turn over. So they're losing hair. It's revving up the metabolism. So they're losing weight. They're having more gastrointestinal function. So they're having, looser stools or even diarrhea. That's the hyperthyroid state. And then obviously hypothyroid, meaning low thyroid, is the exact opposite. So traditionally we think about people who have hyperthyroidism as those people who are losing weight, and people who have hypothyroidism as those people who are gaining weight, right? Like that's sort of the way that we think about it. The problem is it doesn't quite add up all the way because we still have hyperthyroid patients who are gaining weight, as you mentioned. So a couple of reasons for that. There are a lot, and we can dive into these in more detail if we want. But I would say first and foremost, one of the main ways that doctors, it depends on kind of where you're at in this treatment, by the way, if you're going natural or if you're doing the conventional sort of medical route. But let's just assume that you're somebody who is diagnosed with hyperthyroidism. Doesn't matter if it's Graves' disease or toxic multinodular goiter or any of those things, right? It doesn't matter. If you have hyperthyroidism and you go see your doctor, what is your doctor going to do? They are going to reduce your thyroid function, right? They're taking you from a high thyroid level to a low thyroid level, or at least they're trying to bring you to a normal thyroid level. So all of the treatments that you're going to receive as you go to get treated for hyperthyroidism are going to slow down your thyroid, right? And this is kind of the way that I describe it to people is, imagine if you have a level at 100, and let's say that 100 is a normal thyroid function. And let's say that when you're hyperthyroid, that level is 200. So you go to the doctor and your doctor's goal is to take you from 200 down to 100. Using, let's say, methimazole in this case. It could be PTU. Normally it's methimazole, some sort of anti-thyroid blocking medication. So your doctor takes you from 200 thyroid. They try to get you to 100, but they take you to 50. Okay. So in that case, they took you from hyperthyroidism down past your normal thyroid function down to low thyroid function. So they effectively turned you from hyperthyroidism to hypothyroidism with the use of thyroid blocking medication. Now, most of these medications that doctors use, in fact, all therapies for hyperthyroidism do result in hypothyroidism. And we can go through these as these are all therapies that you guys probably know about. We have anti-thyroid blocking medications. We have beta blockers, usually to reduce symptoms, but those can actually cause problems with thyroid function as well. We have thyroid surgery, which is either Hemi Thyroidectomy or complete thyroidectomy, which obviously once you remove the thyroid, that's a problem for thyroid function, and radioactive iodine ablation. So all the therapies that hyperthyroid patients undergo, they result in low thyroid function. So that's probably number one, right? And we'll talk about the importance of thyroid function as it relates to metabolism and controlling various aspects of your body and other areas which are important for your weight. So I'd say that's number one. Number two, we have the people who have hyperthyroidism, that's an abnormal physiologic state. So what I mean is there are problems that are underlying that issue, which are then manifested in the thyroid. So for instance, we have these underlying issues such as inflammation, gut dysfunction, insulin resistance, and leptin resistance, which may have preceded your diagnosis of hyperthyroidism. Now, when you get hyperthyroid, you have these underlying issues that still exist. They can cause weight gain by themselves. So each of these things, that would be one. And then I guess another one that I would add in there would be medications such as beta blockers. So we talked about methimazole and anti-blocking thyroid medications, but other medications including SSRIs, antidepressants, narcotics, these can all impact thyroid function as well. So if you are a hyperthyroid patient taking some of these medications, these can also slow down your thyroid beyond which would be normal for you and lead to weight gain, or at least lead to conditions which then exacerbate weight gain. So I would say those are probably the 3 or 4 main ways, however many we talked about there, the ways that hyperthyroid patients can start gaining weight. And actually this is, I would say, very common. In fact, I think another thing that's worth mentioning here, Dr. Osansky, if I could just take a couple seconds here, is kind of explain the difference between the people that would probably be going to see their conventional doctor versus the people that would be seeing you. So if you were going to go, let's say you were diagnosed with Graves' disease, because that's the most common cause of hyperthyroidism. Let's say that you have kind of one of two options here. You can go take sort of the natural route and try to avoid the anti-blocking thyroid medications using supplements, diet, and lifestyle, which would probably lead you to someone like Dr. Osansky, right? That's what you're probably going to end up doing. Or you can go to your doctor, which is what most people do, and then they go down that path of taking anti-thyroid blocking medications. Now, depending on which path you take, the outcome is going to be a little bit different. So if you're going down the path where you're trying to do things more naturally, you're going to be using supplements perhaps instead of medications generally. So maybe you're using motherwort instead of an anti-thyroid medication or bugle or something like that, right? You might be using one of these, and that is going to they aren't necessarily as powerful as the medications, which means that the thyroid function is not going to go from, let's say, 200 down to 50. Instead, it might go from 200 down to 125. So in that case, you're still borderline hyperthyroid, which makes you're more likely to lose weight when you're doing that route versus taking the more, I would say, aggressive route of using medications. So I think the distinction between which path you're taking, where you're at in the lifestyle cycle in terms of treatment, did you get your thyroid removed? Is it ablated? What type of underlying issues you have? So it's a pretty complicated scenario, I would say, and it really depends on the individual and where they're at. I know it's kind of a long-winded answer, but that's sort of how I would think about it.
Yeah, I mean, I do see a lot of patients on the medication. Usually it's the methimazole and becoming hypothyroid. And sometimes it is extreme. And, and as you said, with the beta blocker too, that could have, that like propranolol could affect the conversion of T4, T3 and some others as well. But very interesting as far as you saying where you mentioned that they could have underlying conditions like insulin resistance, leptin resistance before they were before they actually developed hyperthyroidism, and they might not be aware of that condition because when they go to see the endocrinologist, they're focusing on the hyperthyroidism, doing the thyroid panel, I guess they might do a CMP, a comprehensive metabolic panel, but looking for glucose, but that doesn't always, tell us if someone has insulin resistance. They might do a complete a CBC with differential, but yeah. So as far as insulin, so let's talk a little bit about insulin resistance, leptin resistance, with both, I guess, hyperthyroidism and Hashimoto's. So how do those impact weight loss? Like how do those, lead to problems losing weight?
Yeah, that's a good question. So I think the relationship is such that insulin resistance can cause weight gain, but then also thyroid dysfunction can lead to insulin resistance. So you kind of have insulin resistance as an underlying cause, which may precipitate weight gain. But then once you have the thyroid problem, then that's going to also make worse insulin resistance. So I would say sort of the way to think about it is like this. So insulin resistance, for those of you listening to this, probably have some awareness of insulin and leptin, but insulin is a hormone that is secreted by the pancreas, and its job is really to control blood sugar levels. And so what happens as a result of lifestyle, chronic stress, the overconsumption of sugars and carbohydrates, your body becomes resistant to the effects of insulin inside of the body. And this is very common. It's just, statistics put it as high as 50% of all people in the United States have some degree of insulin resistance. And you can think of insulin resistance existing on a spectrum, wherein some people have very severe insulin resistance and some people have less severe insulin resistance. But I would say just discussing and my experience in looking at people and treating people, most people who end up with thyroid problems already had some element of leptin or insulin resistance before their diagnosis of their thyroid problem. And the problem with insulin resistance is it can stir up inflammation inside of the body. It's a precursor for a lot of conditions, including metabolic syndrome. So it's increasing inflammation, causing problems with cholesterol. It's impacting how well your body's able to utilize sugars inside of the body and where they go. It's actually, when insulin resistance is present, it's sort of sending the signal to your body to push more of the food that you eat inside of your fat cells. So that's what the way that I think about it is, when insulin resistance is present, losing weight is going to be very difficult for that reason. Now, in the case of hyperthyroidism, we kind of have a double whammy thing kind of going on here. So hyperthyroid states do result in insulin resistance, but at the same time, hyperthyroid states, if left untreated, also usually result in weight loss. So you kind of have this ebb and flow wherein the hyperthyroidism is, if causing weight loss, is sensitizing the body to insulin while simultaneously causing insulin resistance. So there's probably, some teeter-tottering that occurs there. And depending on where you're at in terms of your treatment, are you blocking too much thyroid medication? That may tip you more over into the insulin resistance side of thing, as opposed to the insulin sensitizing sort of the equation. So it's sort of a teeter-totter effect there, depending on where you're at with your treatment with hyperthyroidism. Did you also ask about leptin, Dr. Osansky?
Yes.
Okay, so leptin is another story, but I would consider that to be a fat storing hormone as well. Leptin is also a hormone secreted by fat cells instead of the pancreas in this case. And I would say is probably the most important and underappreciated hormone as it relates to your ability to lose weight, especially if you are a thyroid patient. So the way that it kind of works physiologically speaking is that as you gain more weight in your body, as your fat cells accumulate in size, they start to secrete more leptin. And the whole goal of that is for your fat cells to communicate with your brain, because they don't really have a direct messaging system built in. So what they do is they start secreting leptin out, and that leptin floats up to the brain. It triggers the hypothalamus, and it's supposed to be the communication between the fat cells and the brain, that when fat cells are high, to tell the brain, hey, we need to change whatever we're doing. We need to increase metabolism. We need to alter our appetite. We need to alter enzymes and protein production such that we start burning off fat so we can lower these leptin levels, or at least the fat cells, so that we can lower the leptin levels. So that's the communication between leptin, your fat cells, and your brain. Now, the problem is the communication is between the fat cells and your brain in the hypothalamus. And that's sort of the same area that, as you know, and we'll talk about this probably a little bit later, but that's sort of the same area that the thyroid is being regulated. So we have the hypothalamic pituitary axis that then is involved with the thyroid gland as well. So leptin and thyroid hormone are they're connected to each other, such that when you have problems with thyroid hormone or leptin, you have problems with the other. So it's kind of a bidirectional relationship there. So if you have problems with leptin, you'll have problems with your thyroid. And if you have problems with your thyroid, you'll have problems with leptin. And I would say, again, that leptin is one of those that isn't being looked for. We know the importance of insulin because people have diabetes, they have metabolic syndrome, et cetera. I just don't think, at least I'm ordering it a lot, or was ordering it a lot. I don't know. Are you ordering a fair amount, Dr. Osansky, or are you, where do you sit on the whole leptin sort of thing?
Yeah, I can't say I order a lot of leptin as far as, actually, after the first interview, I started doing it more with some patients, mainly if they are gaining weight, having problems losing weight. I do commonly recommend insulin, like doing a fasting insulin along with hemoglobin A1C. So I don't know where you stand on those markers, but yeah. But with leptin, I just, a few months ago, I started, as far as depending on the person. I can't say everybody with hyperthyroidism, everybody even with Hashimoto's. Maybe I should. I don't know.
I mean, I think it depends on their symptoms. I think it depends on what they're experiencing. It's good if weight is in the equation. If weight is a problem for them, then I would always recommend, getting it. You might as well grab it. And the thing is in order to test for leptin, you need to be in a fasted state. And typically I will test for leptin. I'll check for insulin as well, because you want insulin. You want to be in a fasted state for testing insulin. You can check a 8 a.m. serum cortisol at the same time, and thyroid function. So you can get an idea of what's happening in the body by checking all of these hormones at the exact same time. But yeah, I would say in terms of the importance of, I would say leptin, probably number one, number two most important fat weight loss hormone, however you want to kind of describe it, because if it's dysregulated, then weight loss is essentially going to be very difficult. I guess I can kind of talk a little bit about leptin resistance, if you don't mind.
Sure.
So leptin resistance and the diagnosis of leptin resistance is something that I would say a lot of doctors are unfamiliar with. So if you're going to your conventional doctor and you say, hey, can I check my leptin? I heard that, leptin's important for losing weight. I'm not losing weight. What's the deal? And leptin plays a big role in this, obviously. But the problem is a lot of doctors are not really familiar with the physiology that we just described. So in the case of leptin resistance, we talked about the normal physiology here, but let me just explain what happens with leptin resistance. So similar to insulin resistance, if you have leptin resistance, your body becomes desensitized to the leptin that's there. So remember, under normal physiologic conditions, as fat cells increase, leptin levels will increase as well. That leptin's supposed to go to the brain and say, hey, brain, let's make some changes. Let's increase metabolism. Let's change our appetite. And we need to do something so that we can lower fat cells. Now, when you become resistant to leptin, either because your fat cells are inflamed or because you have some other underlying issue like a thyroid problem, which of course many people here will have probably a combination of both, especially if you have an autoimmune related issue. That system becomes dysregulated, and the brain is no longer sensing it. So what ends up happening is that leptin levels increase, right? And your body is, instead of getting the signal that there's too much there, it gets the exact opposite signal. So it kind of thinks that there isn't enough leptin to go around because it's resistant to it. So then what does that do? Well, then that triggers more appetite. That triggers a decrease in metabolism, and now you have the exact opposite of what should be occurring actually happening inside of your body. So this is where people who have thyroid conditions, this is where they get ravenous appetites, where they're already overweight. Maybe they're reducing their calories already to something like 1,500 calories per day. But guess what? They're still gaining weight. They're not losing weight. And meanwhile, their metabolism is as high as it can possibly be. So you have this mismatch between appetite and metabolism, even though you're already overweight and it should be changing, and it isn't. And a lot of that is driven by the mechanism of leptin resistance. So that's where this gets really important, I would say.
Yeah, it makes sense. So because again, similar with insulin resistance, you have higher levels, and that's what you're looking for in a test. You're looking for, the leptin to be high, and, the person's going to have an increased appetite and, still going to want to eat, and that's not going to help. But even, is it safe to say that even in cases like where they are restraining themselves from eating, it still might not be enough? Like if someone just changes their diet with leptin resistance, at least I find that with insulin resistance, there's usually like an inflammatory component. So the person could be following the ketogenic diet and they might lose weight, but it depends on the person. Some people still, even following keto, might struggle, just making the dietary changes alone or even in combination with exercise. So I don't know if you found that when you were seeing patients.
Yeah, definitely. I mean, this is, if you are in a position like ours, where you get to see a lot of people, different patients, you get to see how they react to different diets and different protocols and things like that. It becomes easy to look at it from a different angle than I think what most people do. Because if you're looking at it from the perspective where if you want to lose weight, all you need to do is reduce your calories and exercise more. And if you're not losing weight, then you're not doing that. There's something wrong with that model because it doesn't apply to everyone, especially those people who are in the thyroid situation. So I can recount numerous examples of patients who are eating, 1,000 calories per day. And I have no reason to suspect that they're lying. I believe that they are telling me the truth when they say that, right? Most people will say, well, they're actually just eating more than they say they are. That may happen in some instances, but I believe most of the time people are pretty accurate, plus or minus, let's say 10, 15% of their caloric intake, if they're tracking it, pretty rigorously. Now, the problem is you have a lot of these thyroid patients who are consuming 1,000 calories per day, but still gaining weight. So what gives? And I put them on the ketogenic diet. I put an elimination diet. I've done AIP diet. I've done, carnivore diet. I've done all sorts of different types of diets with these people, and they still don't lose weight. So this tells me that there's something more to this idea that weight gain is primarily driven purely by calories. Now, in the case of thyroid patients, including hyperthyroidism, hypothyroidism, Hashimoto's, Graves' disease, et cetera, and by the way, those people who have had their thyroid removed, I think a lot of it is driven by hormones. So I would say more important than calories, even though calories are important, would be what is happening inside of the body at the level of the hormones. Now, a lot of people know this, right? This is why the whole idea of the ketogenic diet exists. They will say, yes, calories are somewhat important. How important is kind of debatable. But they believe that insulin is the primary driver of weight gain. So they'll say, okay, the whole goal here in our dietary recommendations of, let's say, the ketogenic diet or even the carnivore diet to some degree, is to reduce as much stimulation of insulin as we possibly can. Therefore, we will sensitize the body to insulin and you'll lose weight. Now, the problem is people do that and they still don't lose weight, right? So there's something else involved other than insulin. So I would say, while insulin is important, there are other hormones that are just as important as well, including the thyroid, including cortisol, including sex hormones, including leptin. And I would say insulin is in there as well. So if you are a thyroid patient struggling with weight, I say, my opinion, I've had a lot of success in helping people lose weight, would be to focus more on the hormones as opposed to the calories. Now, yes, you definitely can and should focus on the quality of the food that you're eating and even the quantity to some degree. And we can talk about that if you want. But I'm sure you have seen sort of a similar experience as me, where people are doing exactly what you say, And, I have no reason to believe that they're lying about how much food they're consuming, and yet they're still gaining weight or not losing weight, And so it's like, what do you do at that point? How do you explain this away? And my explanation is that these hormones are taking a front seat, or, a driver's seat. They're the most important as opposed to calories. So that's kind of where I sit on the calorie versus hormone sort of thing when it comes to weight gain.
Okay, makes sense. And then, so let's talk a little bit about diet. So you mentioned, quality versus quantity. So what do you typically recommend when it comes to diet?
Well, I think it depends on the type of person that we're talking about here. So, in this discussion, we're talking a lot about hyperthyroid patients. But I would say the way that you would treat a hyperthyroid patient who's, let's say, undergoing natural therapies to treat, let's say, Graves' disease is going to be different than the dietary recommendations that I would give to somebody who had hyperthyroidism, who underwent a thyroidectomy or radioactive iodine ablation. So we kind of have to stratify what type of patients we're talking about and what problems we have. So in the case of somebody who has, let's say, active inflammation going on in the body, we are highly suspicious. Let's say they have elevated antibodies floating around in their bloodstream. Let's say we'll just use Graves as kind of a prototypical example here. Let's say somebody who is having Graves' disease, they're trying to treat that condition. Maybe they're on methimazole, maybe they're not. I would say that's the type of person that needs to focus on dietary. The goal of their dietary changes should be to reduce inflammation and to alter immune function. So in that case, I would do things like look into diets such as the elimination diet, a whole food-based diet, AIP diet, anything that is reducing any stimulation from foods that might stir up inflammation inside of the body, leading to worsening thyroid function, leading to weight gain, etc. Now, that is different from the person who has undergone, let's say, thyroidectomy or radioactive iodine ablation. That is a person that could be a little bit different in their dietary approaches, because presumably they don't have the same immune inflammation sort of aspect. Yes, they may still have some inflammation underlying their condition, but you can treat them a little bit differently. So that's the type of person that I would probably say you're going to have to focus a little more on fasting. So intermittent fasting, prolonged fasting, water fasting. You still want to be cognizant of the quality and the quantity of the food that you're eating. So any sort of whole food-based diet would be good in this situation. You could play around with ketogenic diet. You could play around carnivore diet. You could play around with any sort of whole food diet. Whole30 would be good in this situation. Pretty much anything, as long as the quality of the food is high. The actual weight loss will come as you start focusing on those other hormones I mentioned previously. But that is a different approach than what I would take for the person who is hyperthyroid, who kind of has that active immune dysfunction that we mentioned previously, because that's someone you probably don't want to put on a fasting regimen. Fasting might make them a little bit worse or cause worsening weight gain. So it really kind of depends on where that person's at. And then also, how are you going to make changes to their diet based off of their personal preferences? So I'm not the type of person that thinks that you can just apply a broad stroke to everybody with a thyroid condition and say, this universally is the best diet for hyperthyroidism, and this is the best diet for Graves' disease, and this is the best diet for those people who have had their thyroid removed, or even Hashimoto's for that degree, right? Or for that matter. I don't think that works. I try to take a more individualized approach to dietary management of any particular patient. And I think that works the best. And I have had people who have lost weight consuming high carbohydrate diets. I've had people who lost weight consuming, high potatoes, lots of potatoes and sweet potatoes in their diet, and lots of fiber and everything in between that you can possibly imagine. And the one thing that I found is that, no two thyroid patients are really alike. They can have similarities, but they're not the exact same in terms of what's going to work for them.
Yeah, I definitely agree. There's no diet that fits everyone perfectly. And I'm glad you brought up the fasting. I agree that when it comes to my hyperthyroid patients, I typically don't recommend intermittent fasting. And interesting when you mentioned like someone gets a thyroidectomy or someone receives radioactive iodine that you do recommend fasting. Mm-hmm. So with Hashimoto's, I'm guessing you also don't recommend fasting, since it's like more of an active inflammatory state, kind of like Graves'.
Well, actually, I do recommend frequently fasting inside of Hashimoto's, and I would say it depends on thyroid function. So my hesitancy in recommending fasting in the case of active, let's say, Graves' disease, in which you're being treated naturally, is that the fasted state might, cause a little overstimulation of the metabolism and lead to worsening weight loss, like beyond the point that you want them to be, right? Muscle catabolism and so on. And you don't want that. But in the case of Hashimoto's, you do have some people with Hashimoto's who have a hyperthyroid state, and they can fluctuate in and out of hyperthyroidism. That's usually uncommon. Usually Hashimoto's is, the low thyroid function generally, but it can fluctuate up and down. Some people do enter hyperthyroidism though with Hashimoto's. So that does occur. But in the case of Hashimoto's, most people are hypothyroid, and fasting actually does have benefits in terms of its impacts on inflammation, and other areas inside of the body. So it is beneficial in the case of autoimmunity. So for instance, if somebody had, let's say, MS, let's say you're listening to this and you have MS or any sort of, lupus, any other autoimmune disease, I still think fasting is highly beneficial for those patients. And so I would say fasting as a therapy, outside of its impact on weight loss, but as it relates to immune function, is still very beneficial. So fasting should be used if possible. And in the case of Graves' disease, I think it can be used, but it should be used cautiously. Hopefully that clarifies my sort of standing on that.
Yeah, it makes sense. There's just concern that it might exacerbate the hyperthyroid state.
Yes.
So really, just to play it safe, you would say probably on average, everyone's different, but on average, the person with hyperthyroidism, even if they're gaining weight, maybe not do the intermittent fasting, at least not right now. Whereas Hashimoto's you do recommend, as well as those who received a thyroidectomy as well as radioactive iodine, correct?
Yeah, that's a good way to think about it. I think, it's all based on the situation, because I do think there are situations in which somebody who has Graves' disease could do intermittent fasting, or start out, as with mild fasting, right? You could do maybe 14-hour eating windows or 16-hour eating windows. When I talk about fasting, I'm generally recommending prolonged fasting, water fast, or even dry fast of 24 hours or more. And those are really where you get these therapeutic benefits that I was mentioning previously. And I'm a big fan of using fasting as a therapy for weight loss, but also, as I mentioned, for treating autoimmunity or just balancing immune function. But again, just be cautious. The worst thing you could do is, if you're listening to this and run out and start doing, a 2 or 3 day fast, and you're already in a hyperthyroid state, and all of a sudden you start catabolizing some of your muscles, that's not what you want to do. So before you run out and do something like that, touch base with someone like a Dr. Osansky or someone else like that understands this sort of philosophy, so you don't put yourself in a worsening situation, because I don't ever want to lead anyone down that path.
How about cortisol? So you briefly mentioned cortisol.
Mm-hmm.
So how does that play a role when it comes to weight gain? Like, especially I imagine high cortisol will have a greater impact than someone who has depressed cortisol levels.
Yeah, for sure. So cortisol is another really important hormone. In fact, I would say, in terms of its impact on weight, is not as important as, let's say, insulin or leptin. I would put those in terms up there as like number 1, number 2. Insulin, leptin, most important fat hormones as it relates to your ability to lose weight. Then I would say you probably have, maybe tied for 3rd, 4th place would be the sex hormones and cortisol. And actually, I put probably thyroid hormone up there at probably the number 3 place. So cortisol is important, but not as important as some of these other ones that we have been discussing. So cortisol, just a brief, sort of physiology for those people who aren't familiar. Cortisol is the hormone that is secreted when you are under a lot of stress. Its whole goal is to sort of help your body adapt to stress. Now, normally that's actually not a problem. It can be a good thing. But much like these hormones, these syndromes that we've been talking about previously, whenever something becomes overstimulated, that's when it becomes a problem. So we commonly refer to this as adrenal fatigue or adrenal related issues, or even cortisol resistance, depending on who you are and who you're talking to. But what can occur is that as cortisol is becoming overstimulated inside of the body is no longer utilizing it as well as it once was. Now, a lot of people will believe that this sort of the way of thinking about adrenal fatigue is that as your body becomes more pressed with stress over a long period of time, cortisol levels tend to increase. And then over time, your body loses its ability to sort of handle that production, and then it sort of peters out and it goes down. Now, I think that cycle of cortisol production has mostly been debunked. I don't necessarily believe that that's the case, because I've seen people who have weight gain who have low cortisol. I've seen people who have weight gain who have high cortisol, and sort of everywhere in between. So my way of looking at cortisol is more of what's happening at the cellular level. But as you mentioned, absolutely, high cortisol tends to be the thing that triggers weight gain. But I think also we have to expand our thinking beyond just what is the absolute cortisol level inside of the blood, and how are the cells able to utilize and manage cortisol. Is it efficient or is it inefficient? And then how does that impact weight as well? So I do think it's worthwhile checking the cortisol. That's why I mentioned in the beginning of this, I said, grab your fasted leptin, grab your fasted insulin, grab your serum 8 a.m. cortisol, grab your thyroid hormones, grab your sex hormones. You can grab all these at the same time, but they need to be looked at in context, and no single lab test can be looked at in isolation. And you can't just look at it and say, oh, my cortisol is, let's say, 16, therefore it's fine. It may be fine, but you also may have some degree of cortisol resistance, in which case cortisol is causing a problem. And furthermore, this is compounded by the fact that there is a close relationship between cortisol function and thyroid function, such that usually, especially in the case of hypothyroidism, but this also exists with hyperthyroidism, changes to your thyroid function will impact cortisol levels as well. So pretty much, this has been my experience, and you could chime in here if you want in a second, but I think I've yet to meet a thyroid patient who didn't also have some cortisol related issue. Now, how you treat that is sort of, that's up in the air. If someone's hyperthyroid, maybe you want to lay off some of the adaptogens or use a more mild version of adaptogens, but I'm a big fan of using adaptogens and glandulars in the hypothyroid patients. So that includes, by the way, those people who have had radioactive iodine ablation and thyroidectomy. In the case of active graves, you might want to use a different type, but you can also do things like meditation and stress reduction and improve your sleep and, you know, mindfulness, et cetera, the nature walks. I mean, there's so many things that you can do to improve your stress outside of taking adaptogen, but I am a big fan of using adaptogens in certain cases of thyroid patients.
All righty. So it sounds like cortisol is a factor, but you would say the top three: leptin, insulin, and thyroid hormone.
Yeah.
And then so cortisol would be potentially, it could be a factor, but would be number 4.
The way that I think about it, this is sort of the helpful way to think about it. I don't think this is exact, but this is sort of how you can think about it. So let's imagine somebody has 50 pounds. Let's say somebody is 50 pounds overweight. Now, the conventional thought might be, okay, that weight is because I've gained 50 pounds of, you know, I've been eating too many calories, right? Now, I would say scratch that and sort of, this is how I think about it when I was treating patients, and this seemed to work very effectively. Some fraction of that 50 pounds that you're overweight is due to, let's say, leptin resistance. Some fraction is due to insulin resistance. Some fraction is due to cortisol, and some fraction may be due to sex hormone imbalances. Because again, the thyroid regulates all of these things. So if you have a thyroid problem, you're going to have problems in all these areas. So what you'll see is somebody who comes in, they get treated. Let's say they start doing ketogenic diet. So guess what? They lose 10 pounds. Well, guess what? You treated the insulin resistant fraction, but you did not address the leptin, you did not address the sex hormones, and you did not address the cortisol. So it's not until you sort of address the complete hormone disruption that is inside of your body that you'll then lose that complete 50 pounds of weight. But everything is kind of contributing either together or in concert, or at least there's never really a case that I've seen where it's like somebody just has 50 pounds of weight gain related to their insulin level, and all they need to do is go on the ketogenic diet and they lose weight because they fix that problem. That does happen, but that's very rare. You know, most common is like somebody does something, they lose 2 to 5 pounds, and then they plateau, and then they're like, well, what's going on here? Well, what's going on here is you didn't address those other issues, those other hormone imbalances that we talked about previously. So that's kind of how I would think about it, or at least wrap my head around it. And that's kind of the way that I would explain it to patients that I would treat in the past. And that seemed to work the best, because we'd address one problem and then look and see how much is left over of what's left. And then we'd say, okay, well, leptin resistance is still here. We know because we just checked your leptin level, it's still high. You know, so leptin needs to be addressed still. And some, you know, let's say they lose 25 pounds, they have 25 pounds left to lose. Well, we need to address leptin in order to get that down, in addition to all the other things we mentioned. So whenever you're trying to lose weight as well, a plan should be multifactorial. It should have a lot of different therapies. It should never just be, I'm going to go on the ketogenic diet and that's that. Yeah, you know, that's a recipe for losing maybe a couple pounds and maybe damaging your thyroid in the process, especially if you're eating pro-inflammatory foods. It's really easy to do some of these diets in the wrong way, you know. So that's how I would think about that. I don't know if that's a little more clear.
Yeah, no, I think it makes sense. Another hormone I want to throw at you, estrogen. So if someone has estrogen dominance, whether it's too much estrogen or, you know, not enough estrogen in relation to progesterone, again, probably I'm guessing not as big of a factor as, you know, the insulin, the leptin, the thyroid, but would you say that could also be a factor? Or?
Absolutely. Yeah, 100%. I would say sex hormones are also heavily neglected by conventional doctors as it relates to their impact on weight. So as you mentioned, let's just say it's less important in men. Testosterone is really important, both men and female, in terms of its impact on immune function and weight loss. And we'll talk about that in just a second. But on the point of estrogen is really important in primarily in women, right? It is important in men as it impacts libido and so on. But for women, it's much more important. And what's really important is not your absolute estrogen level so much as it is the balance between estrogen and progesterone. Now, this is sort of the way that I explain to people. Imagine we took 100 women, we lined them up in a line, and we looked at the physique of each of these women. There are going to be differences in terms of their ratios, their heights, you know, everything, right? Their bust, their weight, their thighs, everything. Now, those differences are primarily related to the impact of these sex hormones on their body during development. So that's sort of how you can think about what estrogen is doing. Now, if there's a relative imbalance of estrogen, such that estrogen is much higher than progesterone, you're going to start to develop certain things. You're going to start to develop weight gain, usually in the breast and usually in the hips and in the thighs and in the butt sort of area, because that's what estrogen does. Estrogen is stimulatory to adipose tissue. That's just physiology 101. So if you have too much estrogen, if you have too much stimulation, the fat cells in those areas are going to enlarge. It's as easy as that. Now, what can happen though is how do you get to this state of estrogen dominance? There's a couple ways you can do that. You can actually have a absolute increase in estrogen levels, which means that, let's say progesterone is here, estrogen can just go up and the gap between the two widens. You can have a reduction in progesterone, which is pretty common, by the way, especially as women are aging. So you kind of have a combination of things where estrogen staying the same, if not falling, but progesterone falling more rapidly than estrogen is falling. So the gap is still widening, even though they're both going down. Then you can also have exposure to endocrine disrupting chemicals or xenoestrogens. These are compounds that you come in contact with. Milk has a lot of these things as well, so dairy products do. And they stimulate the estrogen receptor cells inside of the body, and they act as if estrogen is there, even though it's not. So you can have a relative normal estrogen and progesterone, but due to overstimulation at the cellular level, it is appearing to the body as if estrogen levels are higher than they really are. So that one's like a little more of the, let's say, the more difficult one to diagnose, because you can't really test for it. There's no test for EDCs really, and at least none that are available to most people. But the other ones are more common. You can check for estrogen and progesterone levels, and you can look at the serum levels and see how they're changing. But the problem is women have menstrual cycles, and estrogen levels and progesterones fluctuate over time. So if you don't know how to test estrogen and progesterone levels, then and you're not consistent in how you're testing them and what time of the month you're testing them, then the levels are just going to be sort of whatever. Nobody really knows what to do with them necessarily unless you're testing consistently at a similar interval. But yeah, to answer the question, I think estrogen is very important, especially for women. And I think estrogen causes, the way that I would think about it in women who are gaining weight is you want to look at where that weight is being placed on your body. Because I think where you're gaining your weight can tell you a lot about what type of hormone imbalances you have inside of the body. So for instance, is the weight primarily in the hips and the thighs area? Is it primarily in the breast? Is it in the abdomen? Abdomen tells you something different than it does in those other areas that we mentioned previously. So think about where the weight is think about where you're gaining the weight, and think about the sort of how it's presenting on your body and how rapidly it is occurring. And that can tell you a lot about what sort of hormones you should be looking at. Even if the hormone lab tests aren't exactly 100% indicative of what's happening, you can look at the patterns on your body, and that can give you a lot of information. So real quick, do you mind if I talk about testosterone as well?
No, not at all.
Okay. So testosterone, I would say, is really important as well for both men and women, and especially those people who have autoimmune thyroid disease. So there's some debate inside the medical community as to testosterone and why. Well, let me put it this way. We know that women tend to get autoimmune diseases at a higher frequency than men do. Now, originally, no one really kind of knows why, but some people thought, well, it might be due to the baseline level of testosterone in men versus women, because men naturally have much higher testosterone levels than women do. So women tend to get, autoimmune disease sometimes 8 to 10 times more frequently or more commonly than men. So they thought maybe it's because of that low testosterone. And in fact, we do have studies which show that testosterone is playing a role in the immune system in some ways. So I do think low testosterone is very common in women who have Graves' disease as well as Hashimoto's, because they're both autoimmune diseases, right? And we also know that the thyroid is impacting testosterone levels. And we also know that testosterone impacts your weight through its impact on muscle mass, lean muscle mass, and energy levels, libido, and mood as well. So testosterone, I would say, is very important because it can be used as a therapy to not only treat the underlying autoimmune disease of, let's say, Hashimoto's or Graves' disease, but it can also help with weight loss. So that's assuming, by the way, that your testosterone is low. So testosterone, I would say, I even kind of have said this before, but I kind of think of it as a secret therapy, if you will, for treating autoimmune disease because of its impact on weight and autoimmunity. Treating estrogen is a little more difficult because you really rarely ever do you ever want to give a woman like an estrogen hormone, like a bioidentical hormone, unless they're in menopause. So if you're a premenopausal woman, estrogen's kind of off the table in terms of hormones that you should be taking. Progesterone can be used and testosterone can be used, but estrogen is usually off the table. So that's why I say focusing on testosterone can be beneficial, because increasing that can cause a good impact on immune function as well as weight loss. Now, there are roundabout ways that you can also increase testosterone, such as using DHEA, which, I don't know if you recommend DHEA at all, but DHEA can be sometimes, yeah. So the problem with DHEA is it's a precursor hormone to the other hormones downstream, but giving someone DHEA and hoping that they produce more testosterone doesn't always work, right? Somebody might take that DHEA and use it as a precursor to produce more estrogen instead of the testosterone that you want them to produce, in which case you're worse off than you were. So there are different things that you can do as a patient. You can get testosterone creams and gels. You can use DHEA. Pregnenolone might even be a potential option, and that can also be used for the treatment of cortisol issues and so on. But yeah, the topic of hormone balance and testosterone, estrogen, progesterone can get pretty complex, and it's very nuanced. So I think it depends on the person. It's hard to give broad statements and recommendations for individuals in this setting.
All right. Thank you. Thank you for sharing that. So, what I'm sure some people are wondering the action steps they should take, the solution. So, if someone has hyperthyroidism or Hashimoto's and they're struggling with weight, they're struggling to lose weight. As far as testing goes, the testing, as you kind of mentioned, it does probably depend on the person. But let's say if someone goes to a functional medicine practitioner or just does some testing on your own. These days, you could go into a lab and just test yourself for insulin, test yourself for leptin. So if someone finds out that they have higher insulin and or leptin and maybe some of these other imbalances, how do you get these hormones in balance? What would you recommend?
There's a lot of things that you can do. And in fact, we could probably spend an hour or more talking about treatments, but let me try to distill it down to this. I think I would say the first place that you want to focus is on your thyroid, because that's the thing that I would think will have the most impact in this setting. If you're not a patient with hyperthyroidism or Hashimoto's, you want to focus on your leptin. But in the case of these people that we're talking to, people listening to this, and the patients that you and I, that you treat and I used to treat, they have thyroid problems. So the number one thing that you would want to do first is address thyroid function. Now, let's assume that you are somebody who has hyperthyroidism and you are not taking something like a methimazole. That means what you want to do is address the autoimmune aspect of that. Try to get thyroid function back to normal as quickly as possible. If you're taking methimazole, try to get off of methimazole. The best thing that you can do is get off of methimazole, because methimazole is literally the brakes on your metabolism. So if you're taking methimazole and gaining weight, the single best thing that you can do is whatever it takes to get off of that methimazole. Now, that doesn't mean just yank yourself off of it. That's not what I'm talking about. I'm talking about doing the natural therapies that balance immune system, balance immune function, take supplements that you need to let's say you need fish oil, let's say you need fix your gut, fix, all those underlying issues that we've been talking about previously. That's where I would start without getting too in depth into those. That's, I think, the best thing that you could do for that person. That is assuming that person has Graves, and let's say they're either on methimazole or not. Try to get that under control as quickly as you can. That will give you the most bang for your buck in terms of efficiency. The second thing that you would want to do, which is probably going to go along with the first, would be adjust diet and consider, I would say, fasting. Because the reason I say these is because there are other therapies. We got medications, we got sauna therapy, we got detox therapy, we got cryotherapy, we got all these other therapies that you can look at. But diet and fasting are two things that you are in control over, right? So you may not be in control over what medication your doctor has given you, but you do have control over what you put inside of your mouth. So focus on the diet as much as you can. And then on the flip side of that coin is fasting, is you control what you don't put in your mouth, right? Because you're going without food for a period of time. So I think if you have found that you're one person, if you're in a situation where fasting is safe, use that. No matter what, do your diet. No matter what, focus on the thyroid. When it comes to those people who have undergone thyroidectomy or radioactive iodine ablation, and I'm not sure how many of those people are listening to this, so I don't know how much time to spend on that, but that's a different story. The philosophy of addressing your thyroid is still the same. However, in this case, that means you'll have to address thyroid medication, right? Because in the case of hyperthyroidism with Graves, you're still producing some, in abundance in most cases, right? But in the case of thyroidectomy or RAI, they no longer produce thyroid hormone, which means they are 100% reliant upon thyroid medication as their primary source of thyroid hormone, which means that if you're trying to optimize your metabolism, you have to adjust that medication. And that makes it more difficult because that's outside of your hands. That's in the hands of the doctor. But thyroid function, number one, no matter where you're at, is the thing to focus on. If that means, getting off of thyroid blocking medications, balancing your immune system so that your body stops overproducing it, that will help. That will go a long way with inflammation. Or on the flip side, if you are somebody that needs to take thyroid medication, still that needs to be number one. And then number two and number three would be diet and or fasting. Fasting for sure in the case of RAI and thyroidectomy, possibly in the case of active Graves' disease in which you're not being treated with a thyroid blocking medication. So is that a decent starting place? I mean, we could go into more detail if you want on various other therapies.
No, that's great. I assume also stress management for the cortisol,
sleep, stress.
How about supplementation?
Sure, supplementation. So again, that's going to depend heavily on the type of hormone imbalances that you have. So preceding the treatment recommendations that I mentioned, you always want to get testing first, because testing will help direct the type of therapies that you're going to be focusing on, right? So let's say you get your insulin checked and your insulin checks out that it shows that you have a significant amount of insulin resistance. Well, that means that you can now focus your supplementation on treating the problem of insulin resistance. So in that case, berberine, you could use dietary fibers, konjac, propylmanin, glucomannan is another one of those. Fish oil is really helpful for that. Turmeric is really helpful for that. So there are things that you can use. Alpha lipoic acid. In the case of insulin resistance, you can target supplementations to that particular issue. In the case of leptin, There are, let's say leptin is really high in this case, and insulin is not in the second case. Well, there are some things that you can take, glycosaminoglycans, L-glutamine. Those are particularly beneficial. Fish oil is another one that's beneficial for both leptin resistance and insulin resistance. And I will throw on berberine as well to treat leptin resistance, even though that's more of a insulin resistance type of issue. In the case of thyroid, let's say you're trying to balance your immune system. Well, then in that case, your supplementation will be more directed to your immune system. So you want to be looking at magnesium, vitamin D, and zinc. So it kind of really depends on what the underlying issue is and how you want to address that. I would say universally, though, some good supplements that everyone could benefit from would be a solid multivitamin, vitamin D, probiotics, and then I would say, what else would be a basic recommendation? Magnesium.
Well, you said omegas. You said fish oils,
omegas. I'm trying to think of, like, let's say somebody doesn't know what their lab tests are. These would be the things that you could start with right away. And the whole goal of these wouldn't be necessarily to help with weight loss, but would be to sort of level the playing field, replace lost nutrients so the body is functioning more optimally so that it can take care of itself. Oh, I would also add protein powder in there pretty much regardless of whatever situation you're in. Protein powder is really good for managing appetite, helping build lean muscle mass. It has a lot of other benefits as well. So I'd throw protein powder in that mix of just general supplementation for pretty much anybody with thyroid conditions. You'd be safe to use those.
Any specific type of protein powder like pea protein, whey protein?
Yeah, I would say in the case of autoimmune disease, generally you want to stay away from whey-based protein powders if you have thyroid conditions, especially autoimmune disease. Some people can get away with it. Now, the downside to whey protein, and we can get a longer conversation about this, but actually one of the benefits to whey protein is it has a pretty robust increase. It causes a robust increase in glutathione just naturally based off the amino acid profile, which is amazing for anybody who has thyroid gland inflammation, which is all autoimmune diseases. So we're talking Hashimoto's and Graves' disease, right? So if you would want to use whey protein for the pure benefit of getting more glutathione. The problem is it also has an immunogenic component wherein it can cause worsening inflammation inside the body. So if you can get by with whey, I think it actually can be beneficial in some situations, but you're safe. You're more safe just starting with like a pea-based protein or a plant-based protein. Avoid the whey for now, at least until you can tolerate things, at least until you can get your gut function under control. So stick for the more vegan, plant-based protein powders for thyroid patients, at least to start. And maybe you can dip your toes into the whey sort of stuff. Another one would be egg protein, which actually is pretty good if you can get it. And then you can also try bovine based protein powders as well. Those tend to be pretty good for AIP diets and whatnot. But so you can kind of play around with the various types of protein powders that are available. But I would say if this is getting, if it's getting into the weeds a little bit, just focus on the pea-based protein powder, the vegan-based protein powders. That's probably the best place to start. But do look for fillers, do look for binders, do look for hidden dairy in there, because if you're just going to the grocery store and grabbing like a vegan protein powder or something, you never know what's in it. All sorts of artificial flavors, dyes, fillers, binders. That's all stuff you want to avoid 100%. So make sure you're getting a good quality protein powder that doesn't have many added ingredients.
Yeah, I agree. And I typically don't recommend whey protein. I just threw that out just because a lot of people do consume whey protein powder.
Yeah.
But usually I agree. The pea protein, the hydrolyzed beef for like AIP. Yeah. And even pea protein. I find if someone's like following AIP, usually they could tolerate like a good organic pea protein. And
I think so too. There's a lot of people that will say, oh, I can't use this because I'm on AIPM. Yeah. I really don't see any issue. Usually, obviously there's 5 to 10% of people that just never fit the mold and they always react, but for the most part, I think it's fine. So it sounds like our experience is pretty similar there.
Yes, agree. And as you mentioned, we could go on probably for another hour, but unfortunately, we got to wrap things up, and maybe we'll continue this in the future. But where could people find out more about you?
Sure. So you could go to my website. If you just type in my name, Dr. Westin Childs, the actual website is restartmed.com. You could go or just type in my name or go to restartmed.com. I've got a podcast. I've got a YouTube channel, Instagram, Facebook, Pinterest, you name it, it's all over there. So just head to the website. I've got a bunch of free downloads. My information tends to focus more on hypothyroidism. I do talk about all types of thyroid conditions, and generally the people who are coming to seek information from me, these are people with hyperthyroidism who are now hypothyroid, meaning these are people who have undergone radioactive iodine ablation or thyroidectomy. So I have a lot of information still on hyperthyroidism, but not as much as Dr. Osansky, I would say, because you kind of primarily focus on hyperthyroidism, right?
Yeah, I'd say about 80% of my patients are hyperthyroid. So I do work with some Hashimoto's patients.
Hashimoto's too. Yeah. So it was the flip for me. So, but yeah, I still have information on both, and still obviously enjoy helping patients with any type of thyroid problem. Right? It doesn't really matter to me what they have. That's just sort of my passion.
All right, wonderful. And of course, I'll include links to his website and podcast in the show notes and for YouTube in the YouTube description. And here we're on Facebook, so I'll put it in the comments. But yeah, thank you. Thanks, Dr. Childs. It was great chatting with you again. Look forward to having yet another conversation in the future, whether it's about losing weight or some other topic related to thyroid health.
Let's do it. I think it'll be good. It was a pleasure being on here.
All right, so let's tackle some questions.
Will I be able to see these, Dr. Osansky?
I believe you will.
Okay,
so,
good. Just so I can read them.
So can you see this? Well, yeah, actually, it should be on the screen. So,
Christy.
So Christy, I am hyper and not losing. And then, all right. So I also need to know natural remedies for a hyper. Don't want to go on meds. It made me feel horrible and get pancreatitis. My numbers are not super high. So yeah, as Dr. Childs mentioned earlier, bugleweed and motherwort. When I dealt with hyperthyroidism, I actually chose not to take the antithyroid medication, and I took bugleweed, which in my case did a really good job. It doesn't work with everybody. It's not I would say maybe like 70% of the time, and I still had palpitations, so I took motherwort. And there's others like lemon balm, L-carnitine, but usually I start my patients with bugleweed, and motherwort is also common. So I don't know if you have anything to add to that.
That's about it. I would say, I think the degree of hyperthyroidism also matters. In your case, you're going to be Chrissy, you're going to need to do some testing to see sort of why you're gaining weight. Because if you're not being treated by methimazole, then that means you're having some other underlying issue with it. If that insulin resistance, is that inflammation, is that leptin resistance, is that your sex hormones? You're going to need to do some investigative work to get there. Someone like Dr. Osansky would probably be able to help you because you need the test to figure that out. In terms of the natural remedies, I think, you hit the nail on the head there. The one thing I would say though, is that for anybody listening to this, is that these anti-thyroid medications they never were intended to be used long-term. And they actually have pretty potential profound negative effects on the body. So in the case, it sounds like she got pancreatitis from the medication. I'm not really sure based off of what is being said here, or is that from the natural therapies? It's not clear to me based off of this statement here, but we do know that long-term use of methimazole can cause liver problems, and your body was never really intended to be using it long-term. So anything that you can do naturally to avoid taking methimazole or to get off of methimazole as quickly as possible, that's the route that I would recommend taking.
Sounds good. Yeah, it looks like here, not the natural remedies. It looks like it was the medication that made me feel horrible and get pancreatitis, which I don't see that common. I see a lot of people with elevated liver enzymes with taking the methimazole, sometimes depressed white blood cell count and other symptoms. But again, everybody is different. So let's see. We got Lauren. So my Graves began 3 months postpartum. I had the hardest time losing pregnancy weight, and even now, a year later, I'm still struggling to lose the rest. I also have Hashimoto's antibodies. Eager to hear this because I've never had trouble losing weight postpartum until now. It's so frustrating. Any thoughts on this? I mean, probably what you said. I mean, pretty much the presentation, you gave a lot of information, but
yeah, let me see. Let me just take a glance over that again. So yeah, I would say the one question I have for Lauren here is, is this your first kid, or is this several kids down the line? Because what I've seen is that there tends to be a sort of compounded effect. So the more kids that you have, the more difficult it is to lose weight postpartum. That's just a trend that I've seen. And I think that probably has to do with the difficulty in the normalization of hormones postpartum. Now, in the case of postpartum, generally you do get a bump in weight loss because the production of milk actually it burns a lot of energy, right? It takes a lot of energy to produce that. Let's see. So she has the Hashi's antibody. So she was developed Graves. Now, I guess my question to her would be, where are you at? What level are your antibodies at? Are they getting worse? Are they getting better? You said it started 3 months. Are you 12 months now? Are you 6 months now? I think all this information is beneficial. But again, I would say in this situation, you would need to start with the basics, which is getting the lab test, and clean up the diet if you haven't already. So that's definitely something that you can do postpartum. In the postpartum period, some of the supplements and medications that you can use, that's a little tricky because it sort of depends on you, and it depends on how long you've been breastfeeding, how long you're planning on breastfeeding. But getting the information in the beginning will help direct your future treatment. So And you generally don't want to do a lot of fasting. I should point out in postpartum period, especially if you're breastfeeding, because that can cause the milk to dry up. So you do want to be cautious doing long fasts. I generally do not recommend fasting for any women who are breastfeeding, especially if they have or if they have had known difficulties in milk production. That's something you want to be cautious of. So fasting is probably something that I wouldn't use in this situation. But yeah, testing inflammation would be obviously something that you want to look at. And then diet, because that's probably one of the best things that you can do, because supplements and medications are kind of off the table in this situation. So that's how I look at Lauren's case.
All right. Thanks for that. And let's move on to Julie. So I have Graves' disease, and I'm currently on 2.5 milligrams of methimazole after being on a high dose for a longer period of time, about a year. So I have a 3.7 centimeter nodule, and it's been said to have a 75% of chance of a chance of cancer. So what's your experience with Graves and cancer? Do you want to take this? You want me to take it? Or
I actually don't have a lot of experience in treating patients that have Graves and cancer concurrently. As I mentioned, most of the people that are seeing me are seeing me because after thyroidectomy, after RAI already. So this sort of treatment would be done previously. So I don't know if you have any experience in treating the Graves cancer connection. I don't know that there's anything unique I can add to that situation.
Yeah, I mean, I don't treat cancer either. So if someone has, if it is a case of thyroid cancer, then I'm not saying it can't be treated naturally. I know there are some doctors that focus on cancer treatment. I'm not one of them. So if someone had a cancerous nodule, I would typically refer them out. I mean, a lot of people, of course, would get a thyroidectomy. And again, I'm not saying that's the only option, but if you go to an endocrinologist, that would be, of course, what they're going to recommend, just most medical doctors. But you could always try to find, I mean, the good news about thyroid, most thyroid cancers, they are slow growing. So like, it's not like pancreatic cancer or other types of cancer. So and there are exceptions. There's like 4 different types of thyroid cancer. Again, most of them are slow growing, but you of course would have to find out what type of cancer. And if it is one of the ones that are slower growing, then you could always look into working with someone who focuses on cancer. But yeah, so I don't have a lot to add. I also have, I do have some, interestingly enough, some patients, I've seen a connection between Graves and breast cancer in some cases. And, unfortunately I've had a few of those. And, but yeah, and then, of course, thyroid cancer is getting more and more common, but yeah, so again, I also would say, like, when it comes to nodules in general, as well as like a lot of cases of breast cancer, like estrogen metabolism, we spoke about estrogen dominance. So, so balancing out the estrogen levels and, progesterone, making sure you have healthy progesterone levels. And again, we didn't really talk about estrogen metabolism, but just, like if someone has, I don't know if you're familiar with dried urine testing and a Dutch test that looks at and there's other labs that other urine tests that look at the metabolites. But if someone has too high of the 4-hydroxy metabolite, you could focus on that. Again, for nodules that are non-cancerous, I would actually look into things like estrogen metabolism and even insulin resistance, according to the literature, can play a role in nodules, which is relevant to our conversation here. But when it comes, and again, I'm sure it could potentially benefit, even if it's a cancerous nodule. Since I don't deal with cancer, if I knew someone had a malignant nodule, I just wouldn't feel comfortable, treating that. So but again, that's not to say that those therapies wouldn't help. But yeah, I would, of course, if you're looking to treat it naturally, try to work with someone who focuses on cancer.
One thing more generally, just to add here, is that, so a couple things, the 75% chance is fairly high as far as, statistics go. But there's still a 1 in 4 chance that it isn't. And then number 2, I would say, as Dr. Osansky mentioned, the general advice from doctors is to just pull the whole thyroid out. Now, I would say, I think we're moving away from complete thyroidectomy for every situation into a situation which is more nuanced. And that is, let's try to salvage some remaining thyroid gland if possible. Because when you look at the outcomes of people who have had their thyroid removed, it's not great. Quality of life goes down. An average weight gain of 15 to 25 pounds immediately after removal within about 3 months or so. So they are realizing now that the blanket advice of just removing the thyroid for any condition is probably not great advice. Now, the issue is, in the case of cancer, let's say on one side, what some people are moving towards is Hemi Thyroidectomies, which just says, okay, let's say you have cancer on the left side, let's remove only the left instead of both the left and the right. When traditionally it would say cancer on any side of the thyroid, no matter how big, whole thing comes out. So that was sort of the traditional advice. Now, you might be able to find a doctor, and depending on the type and the histology and what this cancer looks like, how aggressive it is, where it is, how fast it's growing, like Dr. Osansky said, you might be able to find a surgeon which is more comfortable with just a hemi thyroidectomy versus a thyroidectomy, if it comes to that. So, but obviously you want to do the natural treatments if you feel comfortable with that first. But if it's coming down to surgery, and that tends to be where they're trying to push you down, then I would opt for, if possible, at least looking into the hemi thyroidectomy option, because you'll be far better off having half of a thyroid gland than no thyroid gland for the rest of your life. I can tell you that.
Yeah, I agree with that. One also thing, something else that you might want to look into, radio frequency ablation. For some reason, I know for benign thyroid nodules, that's like for larger ones. And I think some research does show what malignancy. So you could always consult with someone. I know University of Virginia does it. There's not a lot of places, unfortunately, but I know one of my patients actually got it done at University of Virginia. And I think they might also address thyroid, malignant thyroid nodules. So that would be a good option if it is an option, rather than get even a partial thyroidectomy, just getting the nodule ablated. The thing is, it's not addressing the cause of it, so it might come back. So you got to keep that in mind. But I'm sure they'll explain that to you if it is an option. Again, I'm not 100% sure.
Yeah. Moral of the story is salvage as much thyroid gland as possible, regardless of whatever you're doing. Right. That's a pretty good general advice, I would say. Yep.
And leptin, you spelled it right. Please spell leptin. You got it.
Yeah. So the lab test that you're looking for is a serum fasting leptin. That's how it's ordered. So yeah, Leptin is how you spell it.
Okay. And this also was this next one was, kind of answered the treatment for leptin resistance. So you spoke about focus on thyroid first, and then diet, focus on diet. Thyroid first. And then like fasting, diet, as long as someone doesn't have hyperthyroidism. And then, spoke a little bit about the supplementation.
Yeah, there's also medications. So there's lots of medications that you can use. I have a blog post outlining those. Generally people get kind of funny when you talk about medications, but in case of people who are 150, 200 pounds overweight, some medications can play a role and can be beneficial, because you're talking about people that have, altered physiologic states, and the medications can push them back into the normal physiologic range and sort of get things moving again. So, and then the other thing that I would say that medications do have a place, depending on how aggressive you want to be. So some people have a significant amount of distress psychologically when they're overweight. Let's say I've seen a lot of people, let's say, for instance, dancers, actors, they'll reach out to me and say, hey, I have got to lose this 15 pounds because I can't not do my job unless I'm, my normal weight or whatever it is, and in that case, there are situations in which you may want to consider that. So yeah, so diet, fasting, supplements, medications, repairing the metabolism is very important. The treatment for leptin resistance is not like one or two things. It's a combined thing. It's a lot of different therapies all put together. And at the root cause, there's no necessarily one root cause, but you want to treat underlying problems. So inflammation needs to be addressed, gut function needs to be addressed. All of these things have to be addressed. So I wish I could say there's just one or two things you could do. It's like, 9 or 10 things in reality that need to occur. And the degree of leptin resistance will impact how aggressive you need to be. So if you are somebody that just has a little bit of mild leptin resistance, then maybe diet and fasting is all you need. More severe, maybe you have to start using thyroid hormone or whatever it is, or trying to get off methimazole even faster. So you have to think of this on a continuum or a spectrum and see where you fit. Now, the problem is for those people, I should have mentioned this. I meant to, but when it comes to leptin testing, as I said, I kind of alluded to this, but doctors are not really familiar with testing. So if you're going to get testing and you get the results, your doctor's probably not going to know what to do with it. So the way that it works is that leptin has a sort of like an increasing value. So let's say that it's based off of your weight. So when you go and get your lab tested, it'll say, I'm just making this range up, but it'll say, if you're 15 pounds overweight, it's 15 to 20. And if you're 20 pounds overweight, it's 20 to 25 or whatever it is. So it kind of scales up. Now, the problem is that's not accurate. A leptin, if you are overweight, a leptin, and you're not losing weight, you have leptin resistance by definition. The leptin value that you get is just helping you understand the severity of how much resistance is actually there. And even then, that's not 100% accurate by itself. So for instance, if you go get your leptin, and let's say you're 50 pounds overweight, and this, just making this up, and your leptin comes back as 35, it'll fall in the normal range. So your doctor will say, oh, your leptin is normal. Well, no, your leptin is not normal, because if you're 35, let's see, I don't know what I said, 50 pounds overweight, 35 pounds overweight. If you're overweight and your leptin is high and you're not losing weight, that by definition is a problem. Leptin's entire point is to help you lose weight naturally. That's the whole point of it. So if you're not naturally losing weight, you have leptin resistance regardless of the level. So don't let somebody tell you that your level is normal when you go and get it tested. So I should have explained that a little bit better in the beginning, but hopefully that comes out now. So if you do decide to go get your levels tested, look at it from the perspective of really a leptin greater than 10 or 12 is abnormal. Now, let's say you go into your leptin's 50 or 70. That's a pretty significant amount of leptin resistance versus, let's say, a leptin of 25 or 17 or something. So that degree of elevation really kind of matters when you're interpreting the lab tests.
All right, awesome. Thanks for that explanation. Do you have time for another question?
Yeah. I got time.
Okay.
Yep.
Okay. So this should be, I think this is, so can you have, so Leanne, can you have Hashimoto's if you have post-ablative hypothyroidism second to Graves' disease? So, I mean, which I would say, yeah, you can have that. If you have Graves' disease, you get, radioactive iodine, and then our hypo, you could still have the antibodies for Hashimoto's. You could have had it, prior to the radioactive iodine.
Yeah. So generally when somebody, I think post-ablative hypothyroidism, does she mean radioactive iodine ablation? I don't know if they can respond back. Is that what she's referring to?
Yeah, that I'm not sure.
Okay. Well, so in this case, because
I'm guessing that's what she means. She's a secondary
okay.
to, but I'm not 100% sure.
Yeah. So it sounds like
she said yes. She responded.
Okay.
She said yes.
So you have Graves' disease. You get radioactive iodine ablation, and then she has elevated antibodies to Hashimoto. So I guess she's saying, can you have Hashimoto's? Okay. So the way that I look at it is like this. So when you have antibodies to something inside of your thyroid gland, so I'm not sure which antibody she's talking about. Let's just say thyroid peroxidase antibody, because that's a common antibody in Hashimoto's. Now, that is an antibody that your immune system is creating to a part or to an enzyme found inside the thyroid gland, which means in order for that antibody to be present, that thing that it's attacking must also be present. So when somebody undergoes a thyroidectomy or radioactive iodine ablation, that you generally see antibody levels fall because the thing that their body is trying to attack has been mostly eliminated. Now, here's the rub. It's impossible to remove 100% of the thyroid gland in really any situation. There's always going to be some fraction of thyroid gland that remains. In addition, some people have portions of their thyroid gland which get trapped during embryonic development as it moves up to where it's supposed to be. So you can actually have extra thyroid glandular tissue. It's not common, but it does happen. So there are people who actually have their thyroid removed, and then all of a sudden they find the thyroid, in their chest or something. I've even heard of people having it around their hearts, like this, or even under their tongues. You can get thyroid gland in weird places. So it's not necessarily uncommon to have elevated Hashimoto's antibodies after RAI or even thyroidectomy, even though that doesn't intuitively make sense. Now, what that means, though, I'd say focus less on the fact that you have this Hashimoto's condition and more on the fact that this is an indication that something's going on with your immune system. That's really what I would be focusing on. I would say, okay, why am I having this reaction, this robust reaction from my immune system to my thyroid gland? That's the issue that I would start to address. So you can start looking at gut function. You can start, which is, we talked, I think in our last one, did we mention molecular mimicry and some of the other things and celiac disease? And I can't remember if we talked about that or not.
I forgot. I honestly don't remember.
I don't either. But in this case, you'd want to look at gut function and immune function and vitamin D supplementation, fish oil supplementation, balancing omega-6, omega-3 fatty acid ratios, or omega-3 to 6 fatty acid ratios, zinc, et cetera. So there are things that you could do. Fasting would be beneficial in this case because your thyroid has been removed with RAI or, ablated with RAI. So that's sort of how I look at this situation.
Okay. All right. Thanks. How about, okay, so you mentioned weight gain in the abdomen, which does this indicate? And that second question, you kind of, as far as dealing with having Graves and Hashimoto's antibodies, I mean, this person, not exactly the same situation, but the other one had the Graves disease antibodies, but then, she had the Hashimoto's antibodies, but really just trying to remove, either way, whether it's Graves or Hashimoto's, for everyone attending, or listening, it's, to me, not, the symptom management aspect is different when it comes to Graves and Hashimoto's, but if someone has the antibodies, it's still autoimmune and you're still trying to remove triggers, correct underlying imbalances, heal the gut. So that's, I think really it doesn't make a difference. I mean, you could have different triggers for different autoimmune conditions, but you're still looking in the same places. You're still doing things with diet, stress management. You might have to look into gut infections. You might not, but it depends on the person.
Yeah, I would say exactly right. So Graves and Hashimoto's they're two sides of the same coin. They're essentially the same disease, just one was triggered slightly different than the other. I would say in terms of underlying conditions, triggers, et cetera. I mean, you even have, when you look at underlying infections that trigger one, they usually trigger both. and so on. But now weight gain in the abdomen, though, that's a little bit different. So weight gain in the abdomen typically is a sign of insulin resistance. Cortisol resistance or cortisol related issues can also cause that. So I would look specifically at your cortisol levels and your insulin levels if it's predominantly in the abdomen. Now, some people will also experience a sort of like generalized weight gain across the entire body, just sort of slow weight gain everywhere. That's usually thyroid function. So that's usually related to the thyroid problem. Hips and thighs and glute areas tends to be sex hormone related. And then upper arms especially tends to be testosterone related. So that's a down and dirty way that you can kind of look at this. I have a blog post which goes over the hormone body patterns of weight gain and how they can kind of manifest. So I would take a look at that if you want to, but generally, yeah, abdomen is cortisol and insulin. So yeah, we talked about insulin resistance and treating that, I believe, reducing carbohydrates, taking certain supplements, reducing inflammation.
You mentioned berberine, so yeah.
Berberine, alpha lipoic acid, fish oil. Yeah, you can kind of go down that route. So in the beginning of this, I'm sure it's going to be posted somewhere, you can kind of go through that. And then Dr. Osensky probably has blog posts on how to treat insulin resistance, I would assume.
I do. Yeah, I have a few articles as well.
Yeah, it's super common. Yeah.
Well, cool. One more thing, and this is really a question. I just want to get your opinion because someone made this post about ashwagandha, just being careful about ashwagandha.
Oh, yeah.
So what are your thoughts about ashwagandha?
Yeah, it's funny. I get this pops up all the time. There must be some people out there telling everybody with Hashimoto's and Graves' disease and autoimmune disease to avoid ashwagandha, because people will say, you need to avoid it 100%, and everybody with these things need to avoid it. Maybe it's some health coaches out there saying it. I don't know who is propagating this, but it stems from the idea that ashwagandha is from the nightshade family, and that if you are of the opinion that AIP diet is the way to treat autoimmune disease, nightshades need to be removed, and they're removed as a part of that diet. And there are other diets which say to remove nightshades and so on. So I think the logic follows that because of this, ashwagandha should be avoided in anybody who has autoimmune disease. Now, practically and realistically in the real world, I do not see ashwagandha to be an issue for the majority of people. In fact, I think ashwagandha, if you look look at the studies. I mean, just go to Google or Bing or whatever you use and type in ashwagandha and thyroid function. And look, there are tons of studies which show the benefit of using ashwagandha in the case of most thyroid conditions, by the way, hypothyroidism, Hashimoto's, hyperthyroidism. So to suggest that it needs to be as a blanket statement that ashwagandha should be avoided, I disagree with that. Now, I do agree that some individuals do seem to have problems with ashwagandha. The percentage varies. I've heard people say anywhere from 5 to 20%. I think it's probably closer to 5%. And the reason I say that is with some degree of confidence, because I have supplements that contain ashwagandha. And, if I'm looking at the amount of supplements that we've, given to thyroid patients, something like 80,000 at this point. And so there's just not that many people that have, it's certainly not 20%, it's certainly not 20%, a couple percent maybe. So I think some people do react negatively to ashwagandha. I've seen it actually be stimulatory to estrogen levels. So in men, I've even had some people, men especially, have some issues with that, and women sometimes do, breast tenderness and so on. So it definitely can do something negative in certain individuals, but I don't think as a blanket statement that it needs to be avoided for people with autoimmune disease universally. In fact, I think the opposite would be better. Statistically speaking, would be a better recommendation, which is pretty much, if you were to say everyone use ashwagandha that has a thyroid problem, I think you'd have better results than saying everybody who doesn't have ashwagandha should avoid, or everyone who doesn't have a thyroid problem, or everyone who has it should avoid it. So yeah, I confused myself as I was talking, but that's sort of how I'm looking at that. But yes, I have no doubt, Maria, that you had a negative reaction to it. So I didn't finish reading all that, but it says,
did she say she had a negative? I guess she just was like limiting. She actually takes it, but yeah. She only takes like 200 milligrams a day.
Yeah, I didn't actually read all that.
Yeah, but I'm bringing it up because I do have like it does seem like, and I agree with you. I do at times recommend ashwagandha. I think most people tolerate it well. But also, in addition to, like it being part of the nightshade family, it does seem, I never had this experience, so I can't relate personally, but some people claim with hyperthyroidism that, that it seems like it exacerbates and I know it affects that HPT axis. So, right. So I'm not saying that's not true, but it seems like in a small percentage of people. So everything's risk versus benefits. And, it's also not something where, like, if someone reacts to the ashwagandha, or let's say not reacts, but if they become a little bit more hyper, what I see is once they stop, it's not like it perpetuates. It's not like it, so when they stop, usually they feel better. So same thing if they're reacting to it because it is a nightshade, So if you disagree with it, if you give it a try, it doesn't work for you, you stop. Usually I have not seen like long lasting effects from like taking ashwagandha. So
Nor have I. And I still think adaptogens just in today's world have so much benefit. So let's say ashwagandha doesn't work for you. Try rhodiola, try ginseng, try holy basil, try maca root. Like you have so many other options that this is the type of thing that you could get, I think, really good personalized care with if you were seeing someone, like a Dr. Osansky or somebody else that has that same sort of knowledge base. Because I see a lot of people who will stop taking something because they read it online or whatever, but then they're missing out on the tremendous benefits that can occur if they did a little bit of tweaking, and it's been my experience that it's the tweaking and the minimizing and maximizing the benefits and that really results in the best outcome for thyroid patients. And so I think that's kind of the thing that, you can't read a blog post to get there. It takes a little bit of experience in treating people and kind of understanding it to sort of get there, even intuition probably a little bit. So if you're listening to this and maybe you tried something that didn't work in the past, I mean, it doesn't necessarily mean you need to 100% avoid that thing. So just as a general parting words of advice, just be careful. And there are things that may appear that they're not working, which can still work. And in the case of hypothyroidism, iodine is one of those. I see a lot of people avoiding iodine for the wrong reasons and so on, but this is a little bit different story here, but I'm just saying it exists across different supplements and nutrients as well.
Yep. All right. Well, thanks again, Dr. Westin Childs. Amazing interview here. Just so much information. Thanks for staying overtime too to answer questions. Appreciate it. And unfortunately, we didn't get to all questions, just too many to answer. But I appreciate you going a little bit over to address as many as we can. Again, we'll have you back in the future to talk more about whether it's leptin resistance, insulin resistance. I'm sure it'll be valuable. And then, of course, can answer more questions. But again, thanks again for doing this. Appreciate it, and look forward to doing it again in the future.
Absolutely. Happy to be here. Thank you, guys.
All right. Thanks, everyone. Have a great day and a great weekend.